Welcome and thank you for attending. This event is brought to you by CooperSurgical, a leading provider of medical devices for women's healthcare. For 31 years, CooperSurgical has worked with healthcare providers to provide highly effective clinic and practice-based contraceptive, surgical, and obstetric solutions. To complement our portfolio of trusted and reliable medical devices, we have also broadened our offerings, investing in the areas of reproductive genomics and in vitro fertilization. We are fully committed to helping improve the delivery of healthcare to women and their families. CooperSurgical manufactures over 600 clinically relevant medical devices used by healthcare providers in offices, clinics, operating rooms, labor and delivery suites, and reproductive IVF clinics worldwide. Clinicians overwhelmingly say they trust our products for their reliability, innovation, and efficiency. Here are some other interesting facts you may not know about CooperSurgical. Since our inception in 1990, our focus has always been women's healthcare. With more than 600 medical devices and over 3,200 product numbers across a broad range of market segments, physicians know and trust our products. We ship over 1,450 orders per day, of which 99.7% are shipped the same day. Our customer service department handles over 2,100 inquiries per day. We employ 1,800 people worldwide. We are pleased to provide this educational opportunity on behalf of CooperSurgical.
Welcome and thank you for participating in tonight's event. My name is Alan Chips, and I will be the meeting manager for this evening's program. A couple of notes on how the presentation will run. We will have approximately 25 minutes for the presentation, followed by a 15-minute Q&A session with Dr. Ziegler. To submit a question, please click the Ask a Question button located under the player window to fill out the form. If your question is not answered, you will receive a response from CooperSurgical following tonight's event. Tonight's presentation is entitled The Role of Office Hysteroscopy for Infertility Evaluation. Dr. Ziegler is a board-certified specialist in reproductive endocrinology and infertility and medical director of the Reproductive Science Center of New Jersey. Now, Dr. Ziegler.
Thank you very much for that introduction. I'd like to welcome all my colleagues from all over the world. And during this lecture, we're going to be talking about the role of office hysteroscopy for the infertile evaluation. I want to disclose that I am a consultant for CooperSurgical, and I'm a speaker for AbbVie as well as CooperSurgical. The main thing that we need to keep in mind for our patients is we need an accurate evaluation of the uterine cavity, because any abnormality in the uterine cavity can affect implantation and could affect the outcome of a pregnancy. We also need to keep in mind that we have macroscopic intracavitary disease, and to see those lesions, hysteroscopy remains the gold standard for the diagnosis and the treatment. When we look at uterine cavity abnormalities, we have to understand the incidence of these defects in which we do see. The prevalence of congenital uterine abnormalities in the general population is only 5.5%. However, hysteroscopic abnormalities are seen in the infertile population up to 60%. There's also an association between endometriosis and endometrial polyps. We find that patients that have endometrial polyps, they have endometriosis in around 68% of those cases. And we also know that structural abnormalities are noted in patients with recurrent pregnancy losses up to 38%. When we treat these abnormalities, we have seen an increase in implantation rates and pregnancy rates. There were some studies that came out that looked at performing a polypectomy before an intrauterine insemination. And the pregnancy rates after an intervention of removing these polyps increased from 28% up to 63%. Miscarriage rates decreased from 27% to 10.7%. When we look at submucosal myomas, we know that they can affect implantation. In removing these, pregnancy rates have increased from 27% up to 43%. So how do we diagnose intracavitary lesions? Well, we have transvaginal sonogram, but the sensitivity and specificity are not that high. We now have saline infusion sonograms. But again, you're looking at a specificity of uterine abnormalities of only 60%. When we take a look at polyps and myomas, they're still quite low compared to doing a diagnostic hysteroscopy, which is the gold standard. So why don't we look inside the uterine cavity? Well, it's convenience. It's not convenient to do. It takes a lot of time. We have to set up the equipment. We have to set up some fluid management system. It's not well tolerated in our office to do a diagnostic hysteroscopy. And the cost to the patient, the cost of the equipment. However, now we have an instrument that allows us to look inside the uterine cavity. And this is the Endosee Advanced. It has a very manageable handpiece. It has a high resolution colored LCD touchscreen, which is reusable. It's able to take still pictures as well as videos. At the same time, you can take a video and take a picture at the same time as you're videotaping the uterine cavity. There is the catheter itself, even though it's somewhat rigid, it is somewhat flexible, and it can help you get into those retroverted uteruses or get into the corneal area so you can see the tubulostium. And the other part is that this has a docking station where you can download the video as well as pictures right into your EMR. So traditionally, when a patient comes into our office, we do an initial screening. We would do follicular phase blood work on day 2, 3, or 4 of a patient's cycle. We would do a sonohistogram or saline infusion sonogram to take a look at the uterine cavity. And if there was an abnormality, we would then need to schedule an operative hysteroscopy. The problem that we were having in our own office is we would get these false positive results, whether the catheter from the saline infusion sonogram dug underneath the uterine lining, and now we have this little flap of tissue that we can't say it was a polyp or not a polyp. In some cases, in patients that we would send for a hysterosalpingogram, we get a result back saying there's an irregularity in the wall of the uterus, and they recommend further testing. So we were actually looking at getting a whole setup, a whole hysteroscopic setup. And then we found the Endosee. And that has revolutionized the way that we do our infertility evaluation. So from the time that we do a saline infusion sonogram, and if there's an abnormality to go for a hysteroscopy, we are delaying a patient's ability to go into treatment by 1, 2, maybe 3 months, depending on when you can get that patient into the operating room. So now what we do is we have a patient that comes into our office. We do an ultrasound. We get blood work on day 2, 3, or 4, and then of their cycle. We do the Endosee. We look inside the uterine cavity, which is the gold standard, to find out whether there's any uterine abnormalities. And at that point in time, everything is negative. We then can go right into treatment. So we have found that it has actually expedited a patient's care on the average of 1 to 2 months to get into treatment. And you have to realize that that infertility patients want to be pregnant yesterday. And anything that we can do to help expedite their care to get them into treatment sooner is going to benefit the patient, and it's going to improve the care you give to that patient. So these are some cases that I want to kind of go through to illustrate the benefit of doing office hysteroscopy. You can see in this patient's case, we did a sonohistogram and we found an irregularity in the uterine cavity. We then did an Endosee. A few days later, we brought her back in after she was prepared to go through the procedure. We looked inside and the cavity was normal. In this situation, we would have had to take this patient to a surgery center to do a procedure of a hysteroscopy. So the patient would have to take time off from her schedule, if she had children, to find daycare for those children or someone to take care of them. They would have to come into the surgery center. They would have to get anesthesia. And as you're well aware, surgical facilities don't always run on time. So And personally, I really don't like the coffee within the doctor's lounge. And I'd have to take time off from my schedule to be there. And in this situation, her cavity is normal. So by looking inside, I have now saved the patient time, in many cases, the patient money, because a lot of them have a deductible to go into a surgical suite, and my time. So this benefits myself as well as the patient. And again, it does expedite their care. Here are some other cases. We did a sonohistogram, and in case 2, you can see that there's this defect in the fundal area of the uterus. This patient, again, we looked inside by doing the endo-C, and her cavity is normal. You can see the 2 tubulosteums, and the uterine cavity is uniform. Just take a look at number 3. There's an irregularity on the posterior wall of the uterus. Is this a polyp? Is this a tuft of endometrium? Well, we looked inside and it was actually a sessile polyp that we actually had to remove. Some patients that have polycystic ovarian syndrome may have an irregular lining like the one you see over on the left. The question is this a normal variant for this patient, or is there something actually going on there that we need to address? And then we take a look inside and we see all these little micro polyps, which again are characteristic in those patients that have polycystic ovarian syndrome. So this is a patient that has a history of recurrent pregnancy losses. And I want to show you the video that this camera can take. So let's take a look at it. You can see here in her uterine cavity, she has an adhesion between the anterior and posterior wall of the uterus. And with the endo-C advanced, you can actually advance scissors to go in there to take out that adhesion in the office without anesthesia. Here are 2 other patients that have a history of infertility. And we take a look inside. The one on the left actually has a uterine septum, and the one on the right has uterine synechia, scarring, which again, we can evaluate quickly, and then we can make a decision of whether or not we can address this in the office with the instruments in which we can pass through the endo-C, or are these patients that we need to take to the operating room? It's a little bit out of the scope of doing these procedures within the office. So this is another patient that came in, and by doing the endo-C, we were able to identify what we needed to treat and treat it quickly to expedite their care. So let's take a look at the video. Now, she had a very thickened uterine lining and no definite polypoid lesion. So I put in the endo-C, and you can see the polyp that is sitting in the middle of her uterine cavity. Now, this patient, I could not remove this polyp within the office. We actually had to go to the operating room to remove this polyp. And after removing the polyp, she actually got pregnant very soon after that procedure. So again, this may have been the reason why she was not conceiving. And therefore, by treating this quickly, again, it made her happy to be pregnant. And we kind of looked like stars because we identified the problem that was preventing her from conceiving, possibly. So this is a patient of Dr. Goldstein. This is a patient who is 27 years old, gravida 0, desired to get pregnant, and they needed to remove the IUD, but they could not see the string. So what they used is the endo-C to look inside and to take out the IUD. So let's play the video. So he was able to identify the IUD and the end, grabbed it with the graspers in the office, and removed the IUD. Avoiding going to the operating room, you can get very good visualization of the IUD and therefore can expedite its removal. This is another patient of Dr. Goldstein's, a patient who has infertility and had uterine myomas. She's 38 years old, gravida 0. She's status post a robotic assisted myomectomy. A hysterosalpingogram was performed. There was no spill from the left tube, and the cavity was distorted. So this is where they looked inside to find out what is distorting the uterine cavity. Let's take a look at the video. That's in the cervix at this point. And you can see there is the submucosal myoma sitting over at 8 o'clock. Again, there are some lesions that we cannot take care of in the office, and we have to know our limitations. So this patient was scheduled for a MyoSure by Dr. Goldstein. Here's a patient who's 35 years old, a gravida 0, has been attempting conception for approximately 2 years. There is male factor infertility. So this patient needed to go to in vitro fertilization. So what we need to do is to make sure the uterine cavity is fine. Make sure it's normal. And I'm not going to trust a patient going through in vitro fertilization, spending quite a bit of money on medications and the procedures on a procedure that's not as accurate as I like it to be. So in this patient, we looked inside of her uterine cavity, and her uterine cavity was normal. So we were able to, again, expedite her treatment and get her into an IVF cycle very quickly. This is a patient who's 36 years old, gravida 1, has been attempting conception for close to a year. She was complaining about breakthrough bleeding. So therefore, what we did is we looked inside of her uterine cavity. We saw this little polypoid lesion. We took the polyp graspers, advanced them through the endo-C advance, grabbed the polyp, and we pulled it out. That's all that needed to be done. Her cavity was now normalized, and then we can proceed on with the rest of her workup. So this was a patient that we saw in our office who's 30 years old, a gravida 3, para 0. She has a history of recurrent pregnancy losses. And when we were doing our ultrasound, the uterine cavity quite didn't look normal. So what I did is we took the endo-C advanced, looked inside, and we diagnosed a uterine septum. We were able to show it to the patient. We could explain to her why we needed to go to surgery, because many patients are very reluctant to proceed to surgery, especially within our current environment. So this helped to identify an abnormality. The patient felt comfortable going to surgery, and we were able, again, to expedite her care. So the advantages of the endo-C advanced: you have direct visualization of the uterine cavity, and that's going to give you a more accurate diagnosis if something is there and if something has to be taken care of either in the office or in the operating suite. The display is clear. It's a colored display. Again, that provides you accurate visualization of the uterine cavity. Within our own office, patients have very little discomfort. We do pre-treat with Cytotec to help us advance the catheter. Patients do take Motrin beforehand, but they get more discomfort from inflating that balloon from a saline infusion sonogram than what they do from when we are doing the endo-C advanced. This can be done in any room in the office. So what I normally do is we set up a room. It could be any of our exam rooms. And my MA goes in, sets up the room. We do the procedure, which takes maybe 2 minutes or 3 minutes to do. And when I'm done, I'm showing the patient the pictures and the video of what just transpired. And during that time, my MA is cleaning the room. And then by the time I leave, that room is already clean, and it just has to be turned over for the next patient. So in doing this in our office, it does reduce visits to the operating room, and therefore it will save you time, and it's more convenient for the patient. As I mentioned, that the average time of the procedure is less than 3 minutes. It's very quick. It's a low-cost investment, and there is reimbursement for this procedure that you're doing within your office. So when we look at reimbursement, these are the codes in which are used for a diagnostic hysteroscopy and for a surgical hysteroscopy. And based on what your negotiated fees are will determine what your reimbursement is. But the reimbursement that you're getting in doing this procedure in your office is just as much as if you do it in the operating suite. And if you have any questions about reimbursement, there is the reimbursement hotline, which is on the slide. It's over to the right-hand side. So the office-based hysteroscopic procedure enables us as physicians to combine a diagnostic approach and how to expedite treatment and how to manage this patient effectively. We don't want to have multiple interventions. We try not to have the patient have anesthesia if at all possible. This approach produces a substantial cost savings to the insurer as well as to the patient. As I mentioned, a lot of patients have a surgical deductible that they would need to meet. Many patients prefer going to a familiar environment of your office. Many patients don't want to go to the hospital or to a surgery center, especially again with the pandemic going on, that they feel more comfortable coming to your office. Also, that the office setting is not as quote unquote sterile of an environment as going to a surgical suite. The physician benefits from the ease of scheduling the procedure because it could be scheduled during their normal office time. It's more efficient use of their time. Also, improved reimbursement compared to taking them to the hospital or to an ambulatory surgery center. And these are things that you need to weigh out. However, it seems to be beneficial for the practitioner to move this procedure into the office setting. So in conclusion, the EndoC Advance gives direct visualization of the uterine cavity. It has high accuracy of diagnosis. You can see septums, polyps, and fibroids, as well as scar tissue. Decreases time to treatment. I know I've mentioned that multiple times during this presentation. It improves patient care because you can directly visualize what's in that cavity versus using an indirect assessment of a sonohistogram that may give you some false positive results. It maximizes your time as a physician. Your time is valuable. So maximize that as best as you can. And again, it's cost effective for both the practice as well as for the patient. So I'd like to thank you for your time, and I hope that you will take the take-home points from this lecture and analyze them and see how they would benefit your patients as well as your practice. So again, I'd like to thank you for your time, and I'd like to open up the floor to questions.